you know, technology is important today, but as we move forward, it will become more and more important. And there is a tipping point happening, I think, across public services and the NHS in particular, where people are recognizing the value of technology and standardizing the approaches that we take. So if we work through our infrastructure, we know that starting perhaps with networks and cloud technology, people are starting to really deploy these at scale, at a minimum across integrated care systems. Now, it's true that, you know, integrated care systems across England have in the main got a long way to go, but that is certainly a clear direction of travel. Without that, of course, we can't rely on the ability to scale applications and scale services at a level which means we can deliver real sustainable benefits going forward. And the infrastructure is needed to be able to do that. You know, there's another dimension to this need to think about technology at integrated care system level as well, which is how quickly can we move from a new innovation, which is operating in a small location, to scale that across at least an integrated care area, maybe larger. Without standard technologies underpinning all of this, it becomes very difficult because you have to make lots of different adaptations to enable that scaling. The more you can standardize, the more effective it becomes. It does mean, though, a big chunk of your investment has to go repeatedly into that area. So any way we can find of making that as efficient as possible is really critical. One of the things that we see in the service historically, and you know, in large part today, is that there are a whole set of artificial boundaries between services in geographically aligned areas. So you know, the age-old question of how does primary care and how do hospital services work together? You know, there's a whole set of interfaces between them which make it difficult, and we rely on, if you like, manual messaging, or have relied on manual messaging to support outpatient referrals and messages back. Over time, of course, we've started to digitize some of that messaging, but nevertheless, it's still an awkward sort of space. Digital now has the capabilities to sort of completely do away with that awkwardness and make that integration of services much more effective. So not only through the capabilities of shared records, but through technologies that allow referrals not just to be sent, but for assessment services with clinical input to really think about whether that patient needs a hospital visit before that's organised, and to advise the GP what the best support for that individual patient might be. And what we see through digital technology is a whole range of different services becoming available through either electronic integration with the patient, electronic advice to the patient. We can see that, you know, much more work is being conducted through areas where patients don't need to attend hospital. So we are moving to a world where routine blood tests, in fact, could be done at home. You know, the patient could prick their finger, put a couple of drops into a file, send it back in the post, rather than having to visit somewhere. Now, that's not, you know, going to be every patient, but we're going to start to chunk at these things. And so we come back to this real big question of how do you standardize the infrastructure to allow that to happen, and how do you make that cost effective? And the only way we can make it cost effective is through driving scale. And the only way that scale will work is to drive the standard infrastructure. So there is this great cycle of things which link together, and it's quite hard to break into. But once we've broken into it, I think, and we're at that tipping point now where that is really on the cards, I think we'll be much more effective going forward. So there are many priorities that people articulate, and if we were to think carefully about what we together felt across the NHS and care and social care, our priorities would be, I think we'd focus on 5 or 6 areas. The work we've done in London with systems and people across London over the last few years has got us to focus on, first of all, routine infrastructure, so cloud technologies, networks, user interfaces, basic digital maturity up to a minimum level across the whole of the system, and as much of the system as possible sharing some of that basic maturity in those applications. From that, then you can start to work out how you can communicate with the patient more effectively at scale through patient health records and various other technologies. You can then work out how you can use that data to identify individuals who may be at risk and getting to population health approaches to help alert about care needs before patients become too ill. You can then think about whether you want to change the way you organize services on the back of those digital infrastructures. So I think, for me, there's a whole question around infrastructure and basic digital maturity at scale. There's then a whole question around patients' access and involvement with the service as the next priority. And then there's a whole question about population health and using that data to drive improvement and alert across the system using sort of compound approaches to flagging problems across the system to drive benefit. So one of the lessons we've learned over the last few years is that we need to make our infrastructure as future ready as possible, and that needs to be a topic which is always on the agenda. And I think what this means is that we're always thinking about how we can get more efficiency, more reliability, more safety and security from our infrastructure, and how we can do that always in a more cost-effective way going forward. One of the big lessons the service has learnt from was WannaCry a few years ago, and that really led to some very severe outages in places across the country. What we understood from that was that we were not investing enough in those standard infrastructure technologies to make sure that that sort of security, safety and reliability was there. The reason that came up, though, was because, of course, like all public services, we're financially pressured. And we had always been focusing, in general, our investments on patient-facing services rather than on services that underpin patient activity, such as digital. And so we sort of lost, the eye went off the ball in some places on that. Now, of course, there's a big local and national response to all of that. But it's still very hard because, organizations will have maybe tens of thousands of end user devices and server, capabilities. And all of that has to be refreshed on a regular basis. All of that has to be thought about. So it's a bit like saying, in financial terms, all of this is a contractual responsibility, and we have to deliver that before we can deliver anything else on top of it. And so there's a sort of a shift going on. Now, there's no doubt we're finding it hard. I think trying to make that shift in financial spend on these infrastructure technologies where, in effect, it may mean you can't see, one additional patient. What it will do is give you confidence that when you do see your patients, nothing goes wrong, or the likelihood of that is significantly reduced. And so we have to get into what I would call this space around negative return on investment. Very often when business cases are presented, we sort of say, well, how many years do we get payback? How many extra patients can we treat? How much income does that bring? That sort of equation. The negative ROI, as I would put it, is, well, actually, if we don't do this, we won't be able to see the existing patients that we see, and that will start to cut off the tap in terms of the income that we need. And that's what we saw in WannaCry. So I think that future ready piece is really critical, and it needs to be a big chunk of the work of the digital agenda going forward. If we're to continue to transform services going forward, one of the objectives is to make sure that the best available data about patients is available to the clinician at the point at which they're making a decision or a judgment about how to look after that patient. The way systems have grown up over the years can lead to organisations being a bit isolated. The agenda for joining up records is really saying, at the point of care in the first instance, why can't we make that data that's digitally recorded available to anybody legitimately who's looking after that patient? And for example, in London now, we've got most of the NHS hospitals, most of the GP practices, a large number of mental health, community and other services connected, so that that data is available to be viewed through what we would call the OneLondon programme. Now, what we need for that is for the people who run organisations across the geography that you're talking about, and London's a big geography, to agree to take a common approach to this. So this comes back to the agenda of standardising at scale and getting the improved efficiencies, but the improved potential for care. Now, as a result of that, in London last month, we had something like 680,000 views of that care record. So it's running at about 8 to 8.5 million views a year. So almost at, the population of London is 9 million, almost at one view per registered patient per year in London. It will carry on doubling. I wouldn't be surprised if in 18 months we were at one view per month, 9 million views a month, the rate that this is now going. But if I can give you one or two little stories. So we have a story of a patient who was admitted while visiting relatives in South London to a hospital that isn't his local hospital, having a heart attack and having some blood tests and being discharged. His GP was in North London. He then went to see his GP a couple of weeks later. The GP was able to see those blood test results from the hospital and was able to appropriately change his medications around, underlying diabetes and so on, without repeating the blood test locally. Another example might be where a family member has brought an elderly parent in to see a GP because the parent's confused and was in hospital in A&E a couple of weeks ago and had a scan of her head because they thought they might have had a stroke and thought that their parents had a history of strokes. The parent was discharged, but the relatives sort of worried that the dizziness is getting worse. That GP could look up the A&E attendance, see the scan and the results of the scan, and was able to reassure that actually this is not a new event, not a new bleed in the brain. This is still resolving, and the dizziness is a result of, developing Alzheimer's probably. So that means that the decision is made more quickly about what that individual needs. We're not wasting resources by asking them to go otherwise back to A&E, which would probably have happened. Now, if you repeat that 680,000 times in a month, just think of all those sort of marginal gains that build up and what that means for a system. So it becomes really important, but you've got to get people to agree to take a common approach. And that's the really hard thing. Technology is great. Humans are harder. We're all very used to, developing our own solutions to problems and, thinking that that's the bee's knees. Sometimes we have to compromise on that to get a benefit across the geography that's wider than our experience. And that's the real trade-off. If you can do that, you can usually get backing for it. And if you can demonstrate the benefit, you'll pretty much always get backing for it. So I would say that it's how you work with people to bring them on board in the service and with your population, with Londoners in our case, to get support for that is really critical. So there's a real need for us to learn the lessons from the pandemic over the last 18 months. One of the things that happened very early on in the first wave of the pandemic was a big switch was made, and many non-patient facing staff started working from home. What also happened was, if you remember in the first wave of the pandemic, we were asked to stop face-to-face attendances where at all possible, either in primary care, in GP practices, or in hospitals, in outpatients, to try and reduce the incidence for the potential of spread of coronavirus. And what that meant then was that those, if you like, clinical discussions with patients took place virtually, either on the telephone or using some other sort of technology, such as video consultation, or indeed asynchronous technologies, so web forms, asking questions and responding back over a period of hours. Some of those have been beneficial. What we saw, if we look at activity through that period, is there was probably, a 20, 30, 40% reduction in face-to-face activity, maybe a 50% reduction in face-to-face activity in some places. But there was an increase in those other technologies, including the telephone, to cover it. And we now see, certainly in primary care, that demand is higher than it was, significantly, probably 10 or 12% higher than it was originally if you add up all those various components. That's creating its own problems in terms of the extra demand. But from a technological perspective, we've now got to deliver our services so that they can be delivered in any location, at any time, with the same level of reliability, resilience, safety and security that we'd expect if they were delivered on an institutional site. And that's the real fundamental change. We've got to make sure the option is available. I think clinically then there are a whole set of questions that need to be asked about what's the appropriate setting for an individual to be seen. But the potential for this is enormous going forward, particularly when we add this with the range of technologies that are emerging around being able to monitor people at home. So, check on people's oxygen saturation, ask people to fill in forms at home, and use that as a way of undertaking assessment rather than face-to-face. So I think this is very significant. It will need a lot of support. It requires a lot of transformation, and it may well need people to think differently about how they work, and patients and the public to think differently about how they receive health and care services. And that's quite hard for people because, we've grown up with this through all of our lives and we're sort of used to it, the models of care. So I think that this comes back to then that real question of efficiency and effectiveness at scale and how you can deliver that to deliver those options of any service at any place at any time. So one of the key underpinning requirements, of course, is to make sure that our data and our applications are stored safely so that we can then access that information to deliver services wherever they're needed. This sort of means that we have to make the shift to cloud services at scale. In reality, that has been happening over the last few years. The pandemic has given that a kick, I think, because it's meant we could add a layer of resilience and cybersecurity with a degree of ease that we didn't previously have. There are some barriers that prevent that from happening. Not every application or every service can move to the cloud, particularly when it's a service attached to a diagnostic machine like a scanner or so on. Then we have to be careful about that. But I would think now that every NHS institution in the country should either be moving or planning very actively to move all their services across to the cloud. Now, what we get from the cloud is, of course, there's a level of reliability, scalability, and cost efficiency that we've not had before. One of the difficulties we get out of it potentially is that there are what I would call edge costs. So if we need to move data around, and usually it's when you transport data in and out of the cloud that you get some costs. So I think getting this set at the right scale becomes really important. And if we look at there are 4 or 5 main cloud vendors in the UK, getting that in procurement terms properly sorted becomes an issue we need to think about and work through. But I think it's a great thing. It does allow a lot more flexibility and ease, takes a lot of the pressure of managing these services off us, and it makes it easier to deliver services to the front line and for patients at any scale, really. One of the other key infrastructure requirements is to make sure that the compliance with security protocols is running at the best level possible. We do know that around the world, code is generated to try and assault our systems on a regular basis, and every service desk manager will be spending some time making sure that the right levels of surveillance are in place, the right patching is in place, and we are prepared as best we can and rehearse those that preparedness for events that start to really impact our infrastructure. So what's happening is that at national level, there is a much greater awareness of the significance of this, and that there's a real push into services to monitor and check locally that they have the right levels of support and surveillance and patching and preparedness in place. So every organisation is pretty regularly audited on this. It's a board responsibility, and increasingly we have applications which allow us to monitor activity locally and report that so that we know what's happening. And I think that's only going to increase. I don't think any of us feel that the threat is levelling off. I think most of us would say the threat is only going to get harder, and that new techniques and new problems will be created that we'll need to solve every day. So this does take, quite a bit of time. A lot of it, though, can be dealt with through thinking very carefully about our infrastructure and our infrastructure refresh going forward, and making sure that we have standard approaches in there rather than allowing too many different flexible applications, too many different applications to be put in place. So it is a balance, and we need to manage that balance carefully. One of the things we see happening increasingly is that in order to give the best care to patients, we have at one end of the spectrum where care is very specialised, we have to get the right specialists together to make those judgments. So, we have something called, multidisciplinary team meetings where people get together and discuss individual patients, their problems, and what the best approach is to look after them. As we have moved forward over the last few years, what we've seen is that there are certain services where that's happening at a bigger scale. And so the teams that need to get together are not just in one hospital, they're across multiple hospitals. They're not just in one part of a region, they may exist across the whole of London. So if you looked at stroke networks in the main hospitals now in London, I think there are 5 hospitals that provide interventional stroke services, then they will get together on a regular basis to discuss complex cases, the specialists in those areas. What this means is then that the services we provide for them to be able to see all the data, have those conversations, need to work very effectively. So that's about making sure that they can have a proper conversation and exchange views and thoughts about what the best steps are. And this extends the previous conversation that we had about not just making applications and data available at any point in any time, but making sure that there are sufficient opportunities to collaborate easily, that haven't got technological barriers, but are technologically enabled, and the user interface is easy to use around those things. Again, the pandemic's helped that somewhat. And what we see, particularly in the end user device market, is that those devices have started to make that much more easy. I mean, for instance, we all use this sort of approach in our non-working environment. If we want to have a conversation with 3 or 4 friends, we can easily call them together on a whole range of different applications on our phone or tablet or PC. And it's just getting to that same level of ease at the work level, same level of reliability, but really critical, because I come back to one of my views, which is really the technology is one thing, but if we can agree to do the right thing, we have the chance of really improving services and the way care is delivered. But then getting humans to support that and working through all the emotional barriers that we have around those is the harder thing. So I think the human side of this can be harder still. We all need to make choices about which services, which companies we work with to deliver the changes. some things we'll want to do in-house, you know, I think that's only normal. But as we make those choices, we need to think about the past track record of services and the companies, whether they've delivered, and what other people, you know, would recommend about those individual companies. And I think we're looking for reliability, honesty, um, technical capability, and for me, actually, the honesty bit is the more important bit. There's a trap, isn't there, to set a contract and think you'll deliver something, but realize that the company you're working with hasn't told you the whole truth, either about their products or about your preparedness and what you need to do, and you don't arrive there. There are some, you know, very well described mistakes, errors, not just in our industry, but in other industries across the world. So I think for me, the capability, the transparency is really important, but I expect partners over the longer term to be really honest and to be a full part of the team in delivering those services. And that honesty for me is what makes them part of the team. At least at that point, you can have a proper discussion with them. If you can't get to that point, then I think that's not going to work. So hopefully that answers that question.